Good afternoon, everyone, and welcome to CDOC's quarterly Cancer Centers Collaborative meeting. My name is Sheila Senyo, she, her, Strategic Alignment Specialist for the COMP Cancer Program and the California Cancer Registry. While we are giving others time to settle in, please feel free to share your name, pronouns, organization, and share your favorite summer snack in the chat. Next slide, please. Again, please feel free to introduce yourselves in the chat so we can get to know who's joining from different cancer centers. Next slide. I'll go over some housekeeping while everyone is typing in their introductions. All participants have been muted, but we encourage engagement and participation throughout the session. While the chat is being monitored for questions, we'll also have an open discussion allotted after presentations. So we hope you can assist us with a short webinar evaluation post-webinar, and then the slide deck, recording, and any follow-up will be sent via email to all participants. Thank you all so much again for taking the time out of your very busy schedules to be here today. Joining us are our Cancer Center Community Outreach and Engagement leads and program representatives, CDOC leadership and other partners, American Cancer Society partners, and CDOC work group chairs. And we also have a few of the CDOC Cancer Plan Tobacco subcommittees in our call today. So before we start with the agenda of presentations, I'd like to acknowledge our CDOC chair, Dr. Sora Tanjusiri from the University of California, Irvine, and co-chair, Dr. Allison Herman from UCLA Jonsson Comprehensive Cancer Center, who are also in today's call to share a few words.
Hi, everyone. This is Sora. Nice to see you. Thanks for joining on these quarterly calls. As you know, I still believe this Cancer Center Collaborative is still relatively among the newer CDOC subgroups, but I cannot think of a more important gathering of folks who are committed to achieving reductions in cancer disparities in our communities. I also want to just say a shout out to Allison, because technically UCLA is hosting the second collaborative Cancer Center collaborative meeting, and this is supposed to be, of course, a shared opportunity for everyone to highlight what they're doing. But I think the things that are going on in Los Angeles around lung cancer collaboration is so remarkable. I'm really grateful to Allison and her colleagues for stepping up to the plate and sharing once again for the rest of us to learn from. So welcome, and I'll turn it to Allison.
Great, thanks, Sarah. And thanks everyone for being here. I actually, this is one of my favorite groups in CDOC. I think it has so much potential to add value to the work that we're all doing, and we haven't yet harnessed all the opportunity for sharing resources and materials. So I look forward to continuing to build on our early successes in this group. And hopefully today is one of those opportunities as well. As Sarah mentioned, we have some great things going on here at UCLA, working to promote lung cancer screening. And as we all know, we're not doing so hot in that area in California, but that means we have a lot of room for improvement, and hopefully we can all help one another and share strategies together. So I'm really excited that Amy Cummings and Ashley Prosper are here. Several of you may have had the pleasure of seeing Amy present at our CDOC annual meeting in person. But just a little bit later, you'll hear from Drs. Cummings and Prosper, and I think it's going to be a great presentation. So thanks for joining. And thanks, Amy and Ashley, for being here.
Thank you so much, Sora and Allison. I'll go over the agenda briefly. So we'll hear some updates from ACS, Comprehensive Cancer Control Program, some cancer plan revision items, and a presentation from our Cancer Center host, the UCLA Jonsson Comprehensive Cancer Center. We'll also provide opportunities for discussion and collaboration, and we'll also have a chance to share and learn about other Cancer Center events, research, and other updates, followed with a quick wrap-up. So to provide American Cancer Society updates, let's hear from Bridget Freely, CDOC Vice Chair and ACS Associate Director, leading state partnerships work with ACS in California. Go ahead, Bridget.
Thank you so much, Sheila, and thank you everyone for this time today. For those of you who don't know me, my name is Bridget, and I'm just here to give some updates from ACS. I did want to acknowledge my colleague Samantha, who's our Senior Director of Cancer Center Partnerships here in California. Usually co-presents with me, but she is on vacation with her family, so I'll be taking over that today. We can go to the next slide. So this is just a reminder and an exciting update from our ACS Lion program. ACS Lion, or American Cancer Society's Leadership in Oncology Navigation, is a standardized online training and credentialing program for patient navigators. And the 2024 physician fee schedule from CMS includes reimbursement for professional non-clinical patient navigation services for patients with a principal illness, which includes cancer and some other high-risk conditions. Training or certification of the navigators is required for their reimbursement. So this training will really ensure that they're able to be reimbursed for their services. And we can go to the next slide. So an exciting update, as there is a cost for ACS Lion, it's about $495 per learner, I believe. ACS does offer an equity support program to reduce financial barriers to the ACS Lion training and credentialing program by offering enrollment to a limited number of individuals who meet certain eligibility requirements at no charge. We're opening up another round of applications for this financial support. It will open on August 30th and then run through September 30th. So if you go on the ACS Lion webpage linked here, you can learn more about information about ACS Lion in general, but also about the support program, eligibility requirements, and how to apply. And you can also email ACS Lion at that email, acslion@cancer.org, with any questions. But I'm also happy to field any questions and forward to them as well. We can go to the next slide. The American Cancer Society and the American Society of Clinical Oncology, or ASCO, are joining forces and creating a one-stop shop webpage for cancer resources. Basically, what this means is that ASCO's webpage, cancer.net, was retired in early June, and now when individuals search cancer.net, it will redirect to cancer.org, with really the hope of having all of our resources in one easy-to-access place. And our teams are currently working together to include relevant ASCO resources on cancer.org, just to ensure that we're providing the best and most comprehensive information and utilizing both of our content. So we hope that this will just help really make it easier for patients to find information about cancer. We can go to the next page. Great. I just wanted to highlight some key accomplishments of our CDOC ACS Lung Cancer Screening Work Group and our ACS CAN colleague, Linda Barber. A lung cancer screening resolution at ACR 196 was chaptered as of late of last week, and this measure proclaims November 2024 as Lung Cancer Awareness Month and the second Saturday of November 2024 as Lung Cancer Screening Day, which is really exciting. And for next steps, members of our work group are going to meet with Assembly and Senate members starting in August to educate them about lung cancer screening and encourage them to educate their constituents. The bill and other information about the bill is linked here if you would like to learn more, but it's just really exciting. As Allison mentioned, we're not doing so great in lung cancer screening, so it's just a really exciting prioritization of lung cancer and lung cancer screening in our legislative efforts. We can go to the next slide. And I just wanted to close out with sharing a little bit of information about an upcoming public awareness campaign, California HPV Vaccine Week. Some of you might be familiar with this already, so my apologies if this is repetitive, but just as a reminder, California HPV Vaccine Week is an annual public awareness campaign from the California HPV Vaccination Roundtable. It takes place during the first full week of August to really raise awareness about the importance of the HPV vaccine as cancer prevention, and also to promote the vaccination of adolescents ages 9 through 13 throughout the state of California. And this year, it's coming up very soon. It falls August 4th through 10th. So this is a really great time for community members, health professionals, and others just to promote the HPV vaccine as cancer prevention in their communities. We can go to the next slide. We've created a variety of materials really to help with this promotion of HPV vaccination in your communities. We do have a full website with a social media toolkit that includes HPV-related cancer survivor stories. We have a story in Spanish. We have a provider testimonial. We also have still image posts like graphics with HPV vaccine facts, with resources available in English, Spanish, and Vietnamese. And there are also suggested captions, social media captions for each resource we have available. We also have our campaign guide on our website. It has all of our social media assets linked, but it also features some key newsletter and email content about the HPV vaccine. There's also a section, excuse me, with instructions about how you can record your own story around the HPV vaccine or HPV-related cancer, with key talking points and how to tag the roundtable. We also have resources for health professionals to learn more about the HPV vaccine and virtual learning events linked. So I'm right here where it says here you can access the full toolkit, social media posts, everything, and more information about California HPV Vaccine Week. We can go to the next slide. This is just a snapshot of some of the resources that I just mentioned. We have 2 new testimonials from last year. I do really want to give a special highlight to Liz Capeel's story. She's a young cervical cancer survivor, and she talks about how her diagnosis impacted her fertility and how the HPV vaccine can help protect your child's future. It's a very, very powerful message. I suggest taking a look. And these are also some of those kind of fact-based posts that I mentioned. This isn't everything we have available, but I think it gives a good sampling. We can go to the next slide. So how can you help us? We're doing a lot on the roundtables end, but we definitely need all of your help to get these messages and resources out there. You can review the campaign content and social media assets with your marketing and communications teams at your organization. You can also share on your social channels if you'd like, and don't forget to use our hashtags and tag the roundtable. I do want to note that these tags here are linked in the toolkit, so you don't need to remember them. You can follow us on social media and engage with our content. That really helps boost it the more people engage. Share links and the assets within your network. And also we recommend pitching stories to local and regional media via your institution's marketing and communications teams, really highlighting the Awareness Week, featuring stories of your providers at your institutions, public health practitioners, or even patient advocates and survivors. We don't have a press release template, but we encourage you to work with your teams. And obviously, we're here to help with any messaging or key points that you might want to include. One last note, I just want to note that these materials, our social media assets and resources are not dated for the most part. So they're really meant to be used at any time that is best for you. You can use them throughout the month. I know August is National Immunization Awareness Month, or you can use them whenever your organization or institution is doing a campaign. But that's really all I had. I don't know if there's time for questions, but I'm happy to answer anything. And thank you so much for this time.
Do you have any questions for Bridget?
I didn't see anything in the chat. And thank you, Joyce, for putting the link to the Vaccine Week campaign in the chat.
Thank you so much, Bridget.
Actually, can I just shout out to Bridget and ACS? Am I the last to realize that much of the information, including at least one HPV handout, is available in many different languages? If you go to the cancer.org website and look at the upper left-hand corner. So again, I could be the last person on this call to actually know this, but thank you, ACS.
And so I know that they're rolling out some more. We have these kind of very easy to read flyers for parents about the vaccine, and we're rolling them out in other languages. They might already be ready, but I know that that's something they're trying to offer more of, so which is fantastic.
This is Kimlin, and this might be a really dumb question, but what's the easiest? I mean, ACS has so much to offer, right? Resources in all space cancer. What's the easiest way to get to all things HPV vaccine?
I would say our national HPV roundtable website, and if you don't, I'm happy to just pop that in the chat so you have it. I think that's probably where most of our most up-to-date resources live, is that's our kind of big, the roundtable's focus is obviously HPV. So I would say there, and then also we have a HPV section of our cancer.org website, which also has some pieces, but I would say our national roundtable website, and I can pop that in the chat in just a second.
Okay, and then to search would be, we could say, like, for parents, for teams, for providers.
Yes, they're actually their resource. If you go to their resource center, and I'll link that specifically on the side, there's like check boxes, so you can check what type of resources you want. So do you want something for community members or parents versus health professionals, et cetera.
Perfect. Thank you. Thank you.
Thank you, Bridget.
Thank you, everybody.
To start off with some CDOC and Comp Cancer updates, I'd like to call on our program director, Shante Davis-Patterson.
Good afternoon, everybody. Hope everybody's doing well. Today, we're just going to go over a few updates. We'll talk about our CDC Notice of Award, our member engagement meeting recap. We had a CDC site visit last week that we'll go over. Then we'll do a quick update on our work group activities and, of course, cancer plan revision. All right, so we got our year 3 notice of award for our comprehensive cancer control grant with CDC. Our fiscal year starts July 1 or June 30th, but basically July to June. We were awarded $425,000. $400,000 of that was base funding. $25,000 is in a special supplement for survivorship activities, and we'll talk about to be used for a little bit later. Our funds are allocated to for 2 positions, survivorship activities, those supplemental funds. Then we had some for travel. We have a Tableau license and a little bit for a contractor to assist with cancer plan development, some of the cancer plan graphic design and things like that, and some training assistance. All right, so our CDOC member engagement meeting that happened last June, not last June, last month. It was last June, but last month, not last year. And many of you were there. It was a wonderful meeting. We had a great time. And do we have another slide on this here? You'll see here all of us there in the room. Okay, and so one of the primary reasons why we gathered was to collect feedback for the state cancer plan revision. You'll see that we had approximately 80 individuals in attendance. We had presentations from Dr. Amy Cummings on the social determinants of health as it relates to cancer, the cancer burden, and then the social determinants of health module on BRFIS. There's a new module for BRFIS. Then we went into our cancer plan breakout sessions and collected all that feedback. You see all that richness there on the board. And we recruited several individuals to serve on subcommittees for the cancer plan revision. So many of you were called to come and represent us at our CDC site visit. We are technically located in Sacramento, but given a lot of you all partners are in Southern California, and most of our team, Sheila and Joyce, are in Southern California, we opted to go down to Los Angeles, and we're very grateful to USC, our partners at USC. Dr. Jennifer Sway and her team hosted us at USC for 2 days while we met with CDC, and you'll see that picture there on the left. The woman in the blue and green dress is our CDC program officer, Ngozi Budias. And that's the rest of the USC team who helps us with our HPV vaccination objective and the announcement approach training. And then also, we want to thank Cedars-Sinai for hosting us physically at that meeting where we were in one room with CDC. We had another CDC representative there as well. But we were able to, present our program, what we're doing. We made some revisions to our work plan. And we also had all of you partners do some presentations. So all of you who are helping us accomplish our objectives in our work plan, we're very, very grateful for the presentations that you provided to CDC. I will say that they are very impressed with California and mentioned that our coalition structure, how we're organized, and the engagement and the involvement of all of our members is really not one of a kind, but they said that they really don't see that a lot in other states. Not that we're the only state with engagement, but they were just very impressed with all of the partners and how everyone comes together in this coalition and actually steps up and does work to help us accomplish our action plan. So again, thank you all for everyone who attended, who represented, because you really helped to paint that picture that we needed to paint for CDC, because it's one thing for them to kind of read a couple of sentences on a paper versus coming to really sit and engage with us. So anyway, thank you again, and thank you to Cedars-Sinai, USC, also City of Hope, really big support to us. So thank you. And then one of the things that we really went over with CDC is really ensuring that what we're doing in our coalition in California really is policy systems and environmental change. So, you know, we have objectives around HPV vaccination, colorectal cancer screening, and survivorship. And we just worked on modifying our work plan to make sure that those activities are PSC related. And, you know, a lot of us know this is basic, but just an example of what that looks like if we're looking specifically at activities, and then how that translates to a PSC change, and then also looking at it with a health equity lens. So if we look at, you know, providing healthy snacks at work, that PSC would be to adopt a healthy vending policy. And then putting a health equity focus on it is to ensure that those products in the vending have a broad variety of tastes and budgets, for example. And so to look at one of our projects with HPV vaccination, we are looking at using the evidence-based intervention of the announcement approach training to increase HPV vaccination. But instead of working toward trying to train as many doctors as we can, we really want to be able to go into health systems and have them adopt this particular training to all pediatricians or all of their providers and those who interface with the HPV vaccine to adopt this and to be part of their standard, you know, policy for training their docs. And then lastly, with cancer plan revision, we are deep into it now. We've been working on this for over a year now. Our cancer plan advisory have been meeting and providing guidance to the cancer plan revision process. And right before this meeting, we had our cancer surveillance subcommittee meeting. So all of our subcommittees are having their initial meetings this week and through August 8th. And we're rolling, we're moving forward with the process. What's happening now, emails and cancer plan revision guidance package resources. We have an extensive guidance package for those who are participating in cancer plan revision. Those were all sent to all who have signed up. I mentioned we have our initial subcommittee meetings. And then the groups are expected to designate a lead for that group, establish a monthly meeting schedule, although we're helping with doodles and things like that. And of course, we're here to assist everyone in this process. And then this is our timeline. We're at the point where you see the darker blue during the first subcommittee meetings. We expect that they'll be working on this content for about a year, and then we'll be submitting it to the Department of Public Health for approval, and hoping that we can get this published and disseminated at the beginning of January 2026. And Joyce has, of course, dropped in that link. If you're still interested, we have closed all of our the sign-up surveys, but if you have that subject matter expertise and you want to contribute to the process and help us out, just contact us and we'll get you going. Thank you so much.
Thank you, Shante. So the Breast and Colorectal Cancer Screening Implementation Project, or the BCIP, Cycle 1 funding is finished, and the final reports are due on August 2nd. So the Cycle 2, they selected 8 FQHCs through a merit review process, and their 6-month reports are also due on August 6th. The funding for Cycle 3 will be from January 1st, 2025 to December 31, 2025. And the projected release of Cycle 3 is on August 12th, with applications due on October 4th. So the application process has some critical changes to the cycle tree. So applicants are strongly encouraged to attend the training. And applicant training is currently scheduled for next month on August 21st at noon. And it requires registration. The Health Equity Work Group continues to work on the SOGI Plus data project. As a recap, we completed the Cancer Center survey in 2022, which asked questions about SOGI data collection within the state's cancer centers. Following the Cancer Center survey, we developed a patient survey to identify the challenges and barriers that patients face in answering SOGI data question. So the survey is complete with 3 Cancer Center pilots either completed or started administering the survey at their cancer center. The next component is the provider or clinician survey. The survey tool has been finalized, and once we have completed the procedural guidelines, we're ready to roll it out at the same pilot sites. So the component of the SOGI project aims to understand clinicians' challenges and barriers in collecting and using SOGI data at their practice. Our community partners grant is moving forward, allowing us to start developing our community survey soon. So the survey will gather feedback from the LGBTQI+ community on how they prefer SOGI questions in medical settings and identify any barriers to answering them. We also have a CCR collaboration, and we're waiting to discuss options for resubmission to NIH. So overall, the aim is to compile information from these surveys into best practices and identify areas for education and training. And this could also involve system changes, direct provider education, or general community outreach. The California recently participated along with 8 other states in a national effort hosted by the National LGBTQ Cancer Network and the National Behavioral Health Network to establish communities of practice or co-op. And representatives from California include CDOC, UCLA, UCI, and Cedars-Sinai. So the co-op will facilitate technical assistance to engage diverse perspectives to explore adaptive solutions and peer learning through guided action plans. Another impact of the co-op is strengthen partnerships and new connections to enhance and sustain tobacco control strategies for individuals with mental health and substance use challenges. The Wellness Within and Latinas Contra Cancer currently implements projects with the psychosocial support groups for cancer survivors. A new RFA announcement for year 3 is forthcoming. And then another activity of the work group are the webinar series on promoting integration of nutrition and physical activity in cancer survivorship programs. The second webinar were presented by Cancer Center partners, Dr. Asher Arash from Cedars-Sinai and Dr. Rasha Bandari from City of Hope presented on the topic. Activities for year 3 will be focused on PSC improvement to support better outcomes for survivors. And one of the proposed projects includes a partnership with Medical to train community health workers to work with cancer survivors. And the last update for the survivorship work group, we recently onboarded a new work group co-lead, Daniel Rivas from University of California, Irvine Chow Family Comprehensive Cancer Center. And I'll pass it over to Joyce.
Good afternoon, everyone. The HPV Vaccination Learning Collaborative is coordinated by the Engaging Health Systems and Providers Work Group of the California HPV Vaccination Roundtable. That's co-led by CDOC. The next meeting is October 16th, and the quarterly virtual lunchtime learning opportunity includes a teaching segment by HPV vaccination experts, field updates, and an open forum for sharing best practices, challenges, and announcements. If you'd like to present your work and share HPV initiatives from your cancer center, please send an email. And I listed the email right here on the slide, and then we'll provide all relevant information links in the chat as well. We want to remind everyone that CDOC welcomes all stakeholders to spotlight their work to recognize individuals who have done exemplary work in cancer control And we encourage you all to share information about your project and outstanding stakeholders by completing a form. And your submission will be featured on the CDOC website, listserv, or in other communications. So if you'd like to learn more about the Stakeholder Spotlight, please check out our website, which I'll drop in the chat. And I'll hand it back over to Sheila.
Thank you, Joyce. Next slide, please. In today's presentation, we'll hear from the UCLA Jonsson Comprehensive Cancer Center. Dr. Ashley Prosper is a radiologist specializing in cardiothoracic imaging at Ronald Reagan UCLA Medical Center. She received her BA degree in biological sciences while minoring in business administration at the University of Southern California. She also obtained her medical degree from USC at the Keck School of Medicine. Dr. Prosper completed an unfolded nuclear medical fellowship during her diagnostic radiology residency at USC in 2016. A year later, she completed a cardiothoracic imaging and intervention fellowship. Dr. Prosper is a diplomate of both the American Board of Nuclear Medicine and the American Board of Radiology. Her research interests include early detection of lung cancer, imaging biomarkers of cardiac involvement for Duchenne's muscular dystrophy, and advancing imaging in pediatric congenital heart disease. Dr. Prosper was the recipient of the UCLA Radiology Young Faculty Teaching Award 2 years in a row. Dr. Prosper is also an active member of the American College of Radiology, serving on the Council's Steering Committee and the Radiological Society of North America, serving on the editorial board of Radiology Imaging Center. Dr. Amy Cummings is a thoracic oncologist who practices in Santa Monica and Torrance. In Santa Monica, she sees lung cancer patients, runs clinical trials, and is part of the virtual multidisciplinary thoracic oncology program that sees patients with thoracic malignancies. In Torrance, she sees patients with all types of cancer and blood problems. Her clinical interests include immunotherapy, precision medicine, and providing equitable care to all patients regardless of race, ethnicity, sexual orientation, and gender identity. In addition to Dr. Cummings' clinical work, she is a research scientist with a PhD in bioengineering. She is interested in how technology can benefit patients, and specifically how informatics and clinical data can be used to improve treatment decisions, access to medical care, and ultimately patient outcomes. She's an active member of the Jonsson Comprehensive Cancer Center, where she serves as the director for the JEDI, or Justice, Equity, Diversity, and Inclusion, and participates in the American Society of Clinical Oncologists, the International Association for the Study of Lung Cancer, and the American Association for Cancer Research, in addition to other professional organizations. Dr. Cummings received her medical degree from the Keck School of Medicine at the University of Southern California, where she graduated with honors and was elected the Alpha Omega Alpha Honor Society. She completed both her internal and medicine residency and her hematology and oncology fellowship at UCLA. During her training, she served as a chief fellow for the Hematology and Oncology Fellowship and co-chief of the Specialty Training and Advanced Research Program, as well as received Olga Levin Inspiration Award in 2016 and a National Young Investigators Award for lung cancer in 2019. A Southern California native, Dr. Cummings enjoyed the beach, live music, and spending time with her family when she's not working. Please welcome Dr. Ashley Prosper and Dr. Amy Cummings.
Well, thank you so much for the incredibly warm welcome. You may have noticed a theme in that both Dr. Cummings and I started out on one side of town and then ended up on the other at UCLA. And yet neither side has disowned us yet, so we're very happy about that. I am going to start off the presentation by sharing my screen. And hopefully you can see it now. I'm going to move Zoom out of the way. And I think we have about 40 minutes, is that correct? Okay, so I'm going to really closely look at my timer because this is a topic I'm passionate about and I could keep you all here for days, but I know that's not our goal. So we're going to talk about a few things that are happening not only locally at UCLA within UCLA's lung screening program, but also on a broader scale, focusing on the University of California's Lung Cancer Consortium, and specifically our lung screening task force. So just a little bit of background. I'm sure you all are very familiar. I'm preaching to the choir. We know that lung cancer is the leading cause of cancer-related death in the United States. This particular graph looks at the rate of cancers for men in the United States, where we see that dark blue line for cancer of the lung and bronchus. We see similar curves for women in the United States. And again, cancers are leading cause of cancer-related death with lung cancer. So knowing that this is the leading cause of death worldwide, we know that it accounts for about 1 out of 5 cancer deaths, and more than colon, breast, prostate combined. I always like to emphasize this fact because when we think about talking to laypersons, people in the public, everyday Americans, they can typically name colon cancer, they can think about breast cancer, they may name prostate cancer, but lung cancer is not as likely to come up. And I think we have a lot to do in terms of PR and awareness to make sure that lung cancer is top of mind. And I think really familiarizing people with not only the risks, but the treatment options that we have to improve longevity for patients diagnosed with lung cancer will really help to alleviate some of the psychological barriers that we have to screening that we'll talk about, such as smoking-related stigma, lung cancer stigma, lung cancer-related fear. Of course, we know that the earlier that we can detect cancer, the better our outcomes. Unfortunately, right now, the majority of lung cancers are diagnosed at a late stage where we already have metastatic disease. And while my hematology oncology colleagues, such as Dr. Cummings, do amazing work with these late stage diagnoses, the earlier that we can diagnose lung cancers, the more treatment options are available at their disposal, as well as some of my other colleagues in radiation oncology, interventional radiology, thoracic surgery, et cetera. So we want to try to move that needle, because when we look at 5-year relative survival, and this is looking at American Lung Association data from 2022, our localized disease diagnoses have a much higher chance of surviving 5 years after their diagnosis. So we want to move things in that direction. Now, keeping a health equity lens in focus, we have to be mindful of the differences that race and sociodemographics play in the diagnosis of lung cancer. This is looking at all cancers combined, data from the American Cancer Society from 2019. And what we see is that as compared to white Americans, Black Americans are much more likely to be diagnosed at a later stage and much less likely to be diagnosed at an early stage than their white counterparts. Now, fortunately, we have a tool to help us with the early detection of lung cancer. I'm sure you're all familiar with low-dose CT screening, where we image the chest using the lowest radiation dose that we can reasonably achieve while still getting good diagnostic imaging. The folks that we screen are according to really 2 main criteria. You all are familiar with the USPSTF criteria, which was recently updated, allowing individuals 50 to 80 years of age with at least a 20-pack year smoking history, either currently smoking or within 15 years of quitting, to be screened annually with low-dose CT of the chest. Of course, we have to remember that for individuals who are insured by Medicaid and Medicare, the criteria are slightly different in that the upper age limit ends at 77. So it's a little unfortunate that we have this slight discrepancy in the eligibility criteria, because it makes the screening criteria for lung screening, which are arguably more complicated than any other screening exam, all that more complicated, where it's a few more check boxes to remember. And what we're really hoping is that we can move the needle with respect to electronic medical record to help make it easier for our primary care and subspecialty physicians to know who's eligible, so that they don't have to do these mental gymnastics to figure it out. I'll just show you a little bit of what I see at the time of lung screening as a radiologist. This is a paper that we did recently looking at different features and textures of pulmonary nodules. So for those of you who maybe are familiar with looking at CTs of the chest, the black area is our normal air-filled lungs with vessels coursing through them. And the denser or whiter areas are different types of nodules that we can see. So depending on the density, the size, the margins, whether or not they distort the adjacent vessels or the architecture of the lung, that helps to give us an idea of how suspicious these nodules might be. And then, of course, we correlate these imaging findings with histopathologic findings. So here are just two case examples of patients who went on to percutaneous needle biopsy using CT guidance. And you can see that, in some cases, we're really worried about something and it might turn out to be just a stellate scar, but our level of suspicion led us to go ahead and get a biopsy. And other times that suspicion correctly led us down the path and we see, a lot of these little round blue cells, we know that this is indeed a lung cancer. So using the imaging clues that we see on CT, we're able to triage individuals to the next best step of management. Through my role with the American College of Radiology, I've helped to restructure LungRads, or our lung CT reporting system. I realize that this is a very small slide in which I've got a lot of text, but I'm going to show you some of the highlights. Really, the goal of LungRads is to structure the reporting of CT so that we can ensure some sort of standardization across multiple sites. So whether a patient is screened here at UCLA or across the country, say at Cornell or Duke or MGH or a small county imaging center, they should be getting the same type of structured reporting that helps to minimize overdiagnosis and to appropriately escalate care for individuals with worrisome findings. You can see that this LungRads chart is color categorized with green meaning everything looks good, come back in a year, all the way up to darker shades of red where we're saying we're more concerned this patient either needs to get a biopsy, come back in a very short period of time, say 3 months, or maybe they need a PET CT because we think that they might have systemic disease and we need to find that. So just a few quick examples. Every once in a while, even though patients are supposed to be totally asymptomatic when they're screened, they might have an infection brewing. And so rather than interpret the screening CT in the setting of an acute infection, we'll say, it looks like they've maybe got a little bronchitis, a little bronchiolitis, maybe some bronchopneumonia. I'm going to hold off on giving a LungRad score at this period of time, and I'm going to have them come back once that infection has been treated so that I don't misclassify an infectious finding as a potential cancer, because that does nothing but stress someone out and maybe prevent them from going to see their pulmonologist or infectious disease doctor and getting the appropriate treatment. We see things that we know are undoubtedly benign. So for example, this nodule here, when I put it on bone windows, I can see that it's densely calcified. I know that this is a granuloma, a finding from an old infection. I'm not worried at all. And so I'm going to phrase my report to say, yes, I see a nodule, but I'm so confident that this is not cancer. Please come back in a year. Similarly, we have nodules where their suspected level of aggression is very low. So here's an example of what we call a ground glass nodule, where you can still see the lung through the nodule. While this may indeed be on the spectrum of an adenocarcinoma lung cancer, the likelihood of this metastasizing or spreading or doing anything really harmful in the next year is quite low. It may also be that it is a sign of a prior infection that left a little bit of scarring. And so again, I can have that patient come back in 12 months and scan them again to see if anything has changed. They don't need a biopsy at that point. Now, as nodules increase in density, as they increase in size, as they develop more concerning features, our escalation increases. We report the size of these nodules using mean diameters, and they guide us in terms of the chart, looking at whether they're solid, ground glass, or part solid, and how big they are. So a nodule such as this one would come back in 6 months rather than a full year. I'll skip ahead and show you how we also use time to help inform our decisions. So for example, this is what I would categorize as a 4B or very suspicious nodule. It's not only large in that it measures a centimeter and it's solid, But when I look at the screening CT from the year before, there was nothing there. And so I'm worried that this might be aggressive or rapidly growing. And I want to see this patient back with more and additional diagnostic information in a short period of time to make sure that I'm not missing a cancer. Now, of course, once the patient gets the CT, that is just the beginning. We need to then triage those results. So we group our results of the screening CT into what we call negative screens, meaning those that have a lung RADS 1 or 2, they can come back in a year, or they need to come back more quickly. Now, the reason that I mention this is because we have a lot of challenges in lung screening. The first is with overall uptake of screening. Now, you'll see these 3 pie charts. This is looking at the rate of lung screening utilization from 2010, before the National Lung Screening Trial was ever published, before we ever had insurance coverage to cover lung screening exams, before Medicaid or Medicare ever signed on. We then have 2015, where we saw the publication of the NLST. We had private insurers who were covering the exam, and we also had government insurance providing coverage from the exam. And you can see that maybe the amount of eligible smokers who are getting the exam has increased marginally, but not that much. And then when we look at more recent data from 2022, maybe it's a little bit increased, but not that much. So we have all of these eligible current and former smokers who could get the exam and have not received it. So when we consider the potential impact, we know that lung screening CTs for eligible high-risk and current smokers in clinical trial data see a 20 to as high as 33% reduction in lung cancer mortality as compared to either chest X-ray or no screening at all, particularly looking at the Dutch-Belgian trial for women who were screened, who were eligible, who saw the greatest benefit in that Dutch-Belgian trial. So there have been all sorts of papers looking at potential life years gained, potential deaths averted, potential healthcare costs avoided, and we're really only seeing the tip of the iceberg in terms of our potential benefits of lung screening, because so few people are actually being screened. Now, I often have to remind myself that lung screening is still relatively new. So if we think about the National Lung Screening Trial being published in 2011, we've really only seen 13 years of trying to get this screening exam up and off the ground. And when we compare this to other more established screening programs, such as cervical cancer screening, colorectal, breast, etc., it's going to take a little while for us to catch up, but I think it's good to have a little bit of healthy impatience to want to really move these things along. This is what's called the Carter-Harris conceptual model of lung screening. Lisa Carter-Harris, or she recently, her name is now Lisa Carter-Bawa, put together this conceptual model of screening, looking at the process of going from being totally unaware of lung cancer screening to becoming an active participant in lung cancer screening and remaining adherent over time. And you can see that there are so many variables that we have the ability to affect change in. So there are psychological variables that I mentioned, such as smoking-related stigma, the fear of being judged for having been either a current or former smoker, the fear of being diagnosed with lung cancer, demographic issues such as age, gender, race, ethnicity, income levels. We've seen all sorts of studies correlating sociodemographics with screening uptake and adherence over time. It's hard for many physicians to understand lung screening, and there's so many eligibility criteria that we have to be aware of, and it's no wonder that many patients are either unaware or unfamiliar or do not understand who's eligible and who is not. But we know that based on other screening exams, we've seen the huge impact that a healthcare provider can have on an individual's willingness to participate in screening. So if we look at data from colorectal cancer screening, we've seen a 23-fold increase in the likelihood of a person participating in that exam if their primary care physician recommends it. And so we really are trying to partner with our primary care providers to make sure that they are comfortable having these discussions with their patients about this exam. Another thing that I really worry about as a director of a lung cancer screening program is how we're doing not only nationally, but locally. And so when I went to analyze our own data, we ended up putting together a systematic review looking at all the published literature that we could find on adherence over time. So meaning lung screening is not a one-time event. We need patients to come back annually as long as they are eligible, because that allows me to do things like when I showed you that LungRad's 4B case where I saw a new nodule and I was all the more worried because I knew there was nothing there before. So this was something that was rapidly moving and I needed to triage that patient quickly. If that patient had not come back on time, just think what that nodule may have looked like 24 months or 36 months down the line. So we need patients to come back according to the recommendation that was given at their last CT. Now, unfortunately, what we see is that adherence rates across the country are quite low. So what this data looked like is we pulled all of the reported adherence in the literature, and we saw that what we call defined adherence, meaning if the paper specifically talked about adherence to a 12-month interval or adherence to a 6-month callback, that adherence rate for patients was only 57%. So just a little bit better than half. If we expanded it to say anytime adherence, meaning I don't care if the patient came back on time or late or early, did they just come back at all? That number only increased to 65%. So we have a lot of individuals who are coming back not at all. So they're coming for just one screening exam and then we never see them again. So we have a great responsibility to fix that. One of the other questions that we asked are, can we figure out who's at risk for non-adherence? So can we look at all of our data here at UCLA and use machine learning and AI development to figure out which features are at the greatest risk of making someone maybe not come back on time? And I'll show you what we saw. It's fascinating. Patients who come and get a negative screening exam at their baseline exam are much less likely to come back. And it might be that maybe they don't understand that they're not clear for life after that one negative CT. Or maybe they're scared about something changing and think, I have a good result, I'm going to stick with that one. There's a lot more work to figure out why individuals might be not adherent over time. But there's some comfort in knowing that those with a more concerning exam, a LungRad's 3 or 4, saying I have a higher suspicion that this might be a cancer in the lungs that I'm seeing on this CT, do have a better chance of being adherent over time. And I really want to thank my postdoctoral scholar, Dr. Jonsson Lin, for helping with this analysis. A few more things before I turn it over to my colleague, Dr. Cummings. I'll point out that demographics play a big role in screening behavior. We're very fortunate to live in the state of California where we not only have a Medicaid fee-for-service program, but it also covers lung screening. That's not true across the United States, as you can see in this picture. However, we're not doing the best. And so we look at this American Lung Association data, and they categorized national data in terms of at a statewide level, how many of the eligible current and former smokers are actually participating in screening. And this red line right here, or orange, all the way at the bottom, and the bottom tier, worst in the country, 50 out of 50, is California. So we have a long way to go to not only catch up to our peers, but to really make a sizable impact in terms of detecting these cancers earlier and seeing the full promised benefit of lung cancer mortality reduction that we see in our clinical trials. Now, I will say there is one caveat to this slide. California has more Medicaid Advantage patients than any other state, and they are not required to necessarily report to a lung screening registry, and so that data was not included in this table. So maybe we're doing a little bit better, but I can tell you we're not at the top, so we have a long way to go. Let's see, other things that I wanted to discuss, what we're doing as a UC Lung Cancer Consortium. So we are blessed in that we have 5 NCI designated comprehensive cancer centers spanning the geography of California. So we know that we have a great responsibility to a large proportion of patients within the state. And so what we have done at the behest of the UC chancellors and our UC president is to come together across all of our cancer centers to try to work together to share best practices, to take on group projects, and to try to share ideas. And this really has to do a lot with the fact that we're down here. So I'll show you a little preview in terms of how we're doing. This data is not publicly available yet, but I'm going to share it with you all to give you an idea of what our work is looking at. So one of the questions we had is, we know what the state level data looks like according to the American Lung Association. What is our UC health system data looking like? And so we created a query in conjunction with the University of California's data warehouse team, which has access to all the electronic medical records for the University of California. We're all on the same platform. And so we decided, a lot of patients that we see at University of California health centers are triaged. So for example, someone who might be diagnosed with a lung cancer and then is referred to see Dr. Cummings because of her level of expertise in thoracic oncology. If I looked at that person's screening data, I may not have it, right? Because they came at a higher level of care once already diagnosed. To have really the greatest meaningful information, we decided to focus on our primary care population that had been within the UC system for at least a year, okay, before their diagnosis. And so focusing on this primary care population, we narrowed the patients that we looked at to those who had a primary care physician who is a University of California physician who had at least one primary care visit in the last 2 years. And then we said, okay, we need to figure out a few things. One, do they have enough smoking data recorded in the EMR for us even to figure out if they're eligible? And then if we do, can we figure out if they've had lung screening? So we started out with a 12-month reporting period. So for example, if we're looking at data from January 2023, the data was pulled between February 1, 2022 and January 31 of 2023. We've talked about our primary care population. We limited it to those who would be eligible for lung screening. And then we mined the data for CPT code 71271, which is the code for a low dose screening CT of the chest. We also looked for this G code, G0296, which is used when a physician has a conversation with a patient about lung screening. So we know that they've been made aware. Is Lung Cancer Awareness Month. Now, this little image of these beautiful lungs with the arborization of the tree branches is from an annual event that's coming up. It will be, I believe, the 4th annual Lung Cancer Screening Day. It takes place on the Saturday near Veterans Day. And this is a co-sponsored event by the American Cancer Society, the National Lung Cancer Roundtable, the American College of Radiology, I believe the UC Cancer Foundation, multiple organizations that have signed on to say, let's make sure that Americans are not only aware of screening, but participate in screening. Now, at our UC Health System sites, we're screening every day, all day, late into the night, weekdays and weekends, but we're using this day to really emphasize lung screening awareness for our patients. And I think it would be wonderful to partner with you all to increase awareness of lung screening as a tool that can help us to detect cancer and to improve outcomes. Now, I hope that I've whet your appetite a little bit to think about recording tobacco history and mining some of that data, because my colleague, Dr. Cummings, has a really ingenious way to help get at that data and improve it. So Amy, it's on to you.
Thank you so much, Ashley. I can't think of anybody else that I'd rather share speaking on this topic with. You were just fantastic, and thank you so much to the organizers for having me here. I know we have just about a little over 10 minutes, so I'm going to take us more into sort of the strategy. How did we get where we were? And this was really a byproduct of the University of California Lung Cancer Consortium. I have disclosures, as many in my field do. And when we were sitting down as the steering committee for this lung cancer consortium, we wanted to tap into the work that had already been done. You know, California has a fantastic cancer control plan. What could we do as an organization to really help bring this to the next level? And so Ashley already showed you this slide about all of the different clinics and places that we have coverage of. And we really wanted to focus in on a mission to reduce the burden of lung cancer on Californians. So we set up our structure with research teams focused on different areas, diagnostics, novel therapeutics. We had core facilities at all of our different UC sites. So all of us could feel like we own something and can contribute. The key initiatives that we identified as part of our original meetings, again, this was launched by Karen Kelly in 2020, along with Sandeep Patel, and all of us joined along. We want to focus on lung cancer screening, molecular testing, and lung cancer awareness, and then support research, training, education, and digital resources as part of our consortium. You saw these data as well. And so what won out of those three topics? Lung cancer screening, because, you know, being a state as big as California, when we're the worst performers in the country, that means so many more people suffer than need to. So this was really sort of easy for us to pick this as our first topic. As we put together the screening initiative, there are really four elements that we wanted to cover. We wanted to cultivate best practices, facilitate research, address access, and support cessation. And when we started to peel apart things, we developed a logic model to help us understand, you know, what are we going to intervene on first, second, and third. And this is really, you know, what you can see in this graphic here. One, how do people find us? How do they know that they need lung cancer screening? Two, how did they get past the front desk? What sort of things need to be in place in order for them to accomplish the procedure? And then three, what are we doing in the back office to make sure that we are not unnecessarily biasing the work that we're doing, that we're making sure that it's equitable and supports all of the principles that we care so deeply about? And so when we came up with the strategic overview of our group, we separated this out into internal awareness, external awareness, identifying other key stakeholders, then a systematic addressing of barriers, benchmarking of our efforts. And again, the goal of our initiative is to increase lung cancer screening in the UC system by 200%. I'm really excited to say that we've already done that, but we certainly need to move on and push beyond that. And then how are we going to iterate? Or how are we going to expand these initiatives? How do we bring more people along with us? And this really requires us to go outside of our UC system and make, you know, our partnerships on the ground with our DHS, FQHCs, other academic institutions. And so here are the milestones since 2020 that we've been able to accomplish. We did identify a lung cancer task force. That's what Ashley chairs, and we're so excited to have her lead our efforts. We've been able to create our UC dashboards. We launched UC Screen California, which is a digital platform I'll share a little bit about. We recently formed a coalition in Los Angeles County for our groups to get together and work on this in a systematic and structured way. And we're now at the point where we're planning to petition for better insurance coverage of lung cancer screening. And so Ashley did a fantastic job explaining our task force and what was going on there. David Cook was her counterpart up north. And of course, Luis Godoy is probably well known to your group, who has really taken over lung cancer screening, and the committee focused on that. We were able to pull great experts from across the UC system to help us. And so just sort of a few metrics to run through. So, you know, 2022 to 2023 in the UC system, we did over 35,000 lung cancer screening exams. We did increase our screening from about 10% to 20% with identification of that primary care population that Ashley talked a lot about, that represents a little less than half of the total lung cancer screenings our institutions do, and inclusions of codes for the lung cancer screening discussion. That was, again, a very key piece of this. Smoking history was captured on 21% and did increase. That documentation increased by about 8% from 2022 to 2023. We had about 15% that opted out of lung cancer screening, and the proportion of those undergoing an initial screening decreased by 17.1%, while those with the previous screening doubled. So this was really important to show that we were actually moving patients beyond that first screening into subsequent screenings. And overall, our lung cancer screening did grow by about a quarter, 25% from 2022 to 2023. Ashley mentioned that these data are unpublished and we're in the process of preparing them for publication now. And so, again, this is going to be something that we continue to promote. We're going to publish on this and make sure that we're benchmarking and utilizing well the information that we've assembled. Now, to go into UC Screen California very quickly, there really were three components to this initiative. We wanted to engage with community, engage with our providers, and then provide some networking opportunities. And so we did a series of events across the UCs in November. You can see some optics from these here. This was so impressive that President Drake did mention our Lung Cancer Consortium by name in his update on his system-wide priorities, and lung cancer screening has been brought to his attention because of the work that we've been doing collectively. We also launched something called UCScreenCalifornia.org. This is a website that you can go to in this minute to, one, identify if you are eligible for lung cancer screening, and then get navigation to services. This is in the public domain. This means that UCs do not own it. You can copy it today if you wanted to, although we'd be happy to partner with you. And this is a tool that we're going to be taking and rebranding in some ways to make a non-UC form available for anybody that's in California. Now, as we took a look at these data from the first 45 days that we were using it, we also had over 100 people give us feedback on whether or not they'd recommend this tool and did they find it was easy to use. They said yes to both of those. We did have over 10,000 page views with 600 submissions. The languages that were used: English, Spanish, Cantonese, Korean, and Norwegian. About 15% were eligible for lung cancer screening based on the data that was input into this application. The average time to completion was 102 seconds. We said that it should take less than 2 minutes, and it does. Now, very interestingly, and to Ashley's point as well, those that started but did not complete the survey when they're finding out whether or not they're eligible for lung cancer screening, 92.3% stopped at the smoking history section. The way that we are capturing smoking history by asking about pack years and time is complicated. And so what we're working on now are efforts to make these questions different so they don't necessarily stop somebody and lead them to not complete that questionnaire. Of those that were ineligible for screening based on these assessments, and again, we had sort of a distinction between those that were just using it to figure out how it worked and those were actually completing it for themselves. Over a third were ineligible, not because of the amount of smoking they had, but because of their age. So that shows us that they're going to be a group of cohort of patients that are going to become eligible for smoking screening for lung cancer. And we need to make sure that we're going to be able to control and handle this influx of patients. And then I think one of the key value adds to using an app like this was that for those that requested navigation, we were able to actually reclassify some to get diagnostic imaging as opposed to screening because they did have symptoms related to lung cancer. And so we're going to continue to promote this. We're going to make this available to other systems. Again, this is in the public domain. This isn't something we wanted to own. We wanted people to use it. And so we're going to continue to leverage this in our lung cancer screening events. And in the last minute, I'm just going to talk very briefly about the regional partnerships that we're forming. Love Your Lungs up in Northern California, I think, has been a great example for us in terms of how different organizations can get together for the greater good of lung cancer screening. We're hoping to plug these regional partnerships into the California Plan for Control. And in Los Angeles County, we were able to put together a group that included all of our academic sites, 2 of our main FQHCs, Healthcare LA IPA, as well as AltaMed, as well as our county facility, and to bring everybody together, representatives from Kaiser, from Antelope Valley, from those that are representing indigenous populations, and to get everybody together to start to think through what's going to be their strategy in the plan. And so we were able to put in, through sponsorship for the American Cancer Society, a structure that's going to help us continue to do this and get this funded on the ground. I'll show you just a couple slides from these group meetings. Our mission and vision is really to focus on disparities in Los Angeles County and really coordinate care and research in a very high needs area. We know that resource distribution is lowest in those that need us most. And so we were able to identify target areas and things that we can come together on to support. We know that structural racism is at play, particularly with PPM 2.5. Is this how we're going to move the needle for who else we're going to screen in the future for lung cancer? And then, of course, the Medicaid reimbursement, kind of pulling the rates and showing that California, despite being the 5th largest economy in the world, gets less for its public health safety insurance than any other state. So as we look at the strategic plan, we're going to work on awareness and education, collective advocacy, pathways, interoperability, and technology solutions and partnership in the greater screening landscape. So that was somewhat of a whirlwind, but I did want to make sure that we got through some of the key pieces of what we're doing for strategy, for partnerships, how we're making our voice louder together. And again, I've just reinforced the idea that even though we do have a University of California Lung Cancer Consortium, that's not it by itself. We need our local and regional groups to bring everyone along, and we very much want to be a part of that. And by having a third party like American Cancer Society sponsor it, I think, you know, having honest brokers to keep us all in this together and coordinating the work that we're doing, I'm really excited about how we can support California's cancer plan. So thank you.
Thank you so much, Dr. Prosper and Dr. Cummings, for your time, effort, and expertise in presenting your collaborative lung cancer screening work. With this, I'd like to open the floor for any questions or comments. We received some comments on the chat. And I also received some direct message asking if they can have a copy of your presentation. I'll follow up after the call.
Yes, that would be acceptable to me. We may remove that preliminary data from one slide, but other than that, yes, happy to share.
Thank you. And I see Jesse's hand up. Go ahead, Jesse.
Hi, can you hear me okay?
Yes.
Great. Excellent presentations, Dr. Prosper, Dr. Cummings. I'm down at UC San Diego with Dr. Patel and crew. So I'm the unit I work most closely with is community outreach and engagement within our cancer center. I'm at Morris Cancer Center, like many of us are cancer center linked. And we do a lot of our prevention research with FQHCs, right? Community health centers, which is a different population that is being treated at UC Health Systems. And the data that you presented are for UC Health Systems. But it's interesting, the consortium or the LA area group that you put together to a large degree is going to be focused on disparities. So I'm kind of curious what kind of dialogue you had already in two areas. One, how the UC data, the patient profiles, whether it's cultural, socioeconomic, linguistic, how that informs our serving FQHC patients better. So that's one question. And then the second question is whether you've begun to broach the issues of referrals from FQHCs to lung screening specialty clinics within the UC infrastructure. Because I think for us, those are two probably of the key things that we're going to have to broach in the near future if we're going to be effective in serving these individuals that are largely Medi-Cal and Medicare, but mainly Medi-Cal funded or insured, I should say. Sorry.
Yeah, and so Ashley and I were both on a call not that long ago where we were talking with our DHS counterparts, and the issue surrounding a capitated system is just very different than most of the work that's been done, you know, with lung cancer screening and how we're starting to address this and what the financial barriers and risks will be. So I would say, you know, there've been two main requests as a result of the engagement that we've had. One is to really work on a model for a capitated system, how this looks, to again kind of prove not necessarily compared to our UC population, but to other, you know, safety net populations, FQHC populations, what screening is looking like and sort of where they are and what are the equity markers of inequity within these systems, not compared to our system. And so we're working with a health economist to come up with that. And that's certainly something that we're looking to share more broadly, because to have sort of a comprehensive lung cancer screening program in our DHS system and with our FQHCs, the barriers that you noted are real. You know, again, for downstream referrals for thoracic surgery, to have a thoracic radiologist read these images, there are a lot of issues there. And so one is we're going to just sit down and work on a model to help us understand this better. This is what's in the works right now. I think the other piece of information that we've gotten from Melanson Briggs, Medell Melanson Briggs, who is one of the chief equity officers for the UC system, is that we need to take this information and bring it to our insurance carriers and to our payers, because we have to advocate together for better reimbursement rates for downstream care if this is something that's going to be feasible. The feedback that we've gotten from our leadership was if we were to sort of open up our doors to referrals from our sort of Medi-Cal system for the procedures and other care that they would need, that it could bankrupt our system. And so that's not tenable, and that certainly is inexcusable. And so that's one of the key things that we want to lead on and push on in terms of advocacy. And so in the meantime, with these local regional partnerships, can we figure out a way to chip in together and make sure that we're able to provide this downstream care and support our insurance, and support people? That's the whole point of this, because we know that when each of us has lobbied our C-suite alone, we've gotten turned down. But if we all come at it together, when we say this is something we're going to do across every reputable academic and medical system there is in this county, are you going to do so as well? That has a lot more power to it. So that's what we're working on right now. But your questions are fantastic and very much the concerns that we've had.
I'll just throw in one other tidbit that I think is really important to keep in mind. There was a study that was published in the Journal of the American College of Radiology about a year ago, looking at lung screening adherence based on how high of a copay patients have with their insurance status. And the higher the copay, even though lung screening is a covered benefit and they should not have to pay for anything out of pocket, just knowing that other exams have had a higher copay, those patients are less likely to engage in lung screening CT, which is totally covered and should be free for those annual screening exams. So the questions that you asked are so important, because the background that patients face with their income level, their resources, and then the type of insurance that they have plays a big role in whether or not they participate.
You know, I have a question, but can't seem to raise my hand. Am I okay in queue? Sheila, just give me a thumbs up.
Go ahead, Mark. And then
Thanks.
I'll call on Lucy next.
Oh, I'm sorry. I can't see the hands. So thank you very much for the presentation. Very, very helpful, very thorough. I guess I'm queuing a little bit more after Dr. Cummings' presentation, in particular around county health, local health jurisdictions. I realize, the local health jurisdictions are pretty inundated, probably more focused on things that are going to hit epidemic proportions soon, more, STDs or COVID or whatnot. So the question is this, do you have or recommend some engagement at the local health jurisdiction level? And if so, how? I'm with the Department of Public Health. I kind of work with the California Cancer Registry. And one thing that we've done recently, particularly as motivated by COVID, was establish a new sort of at a center level, very high level, a focus on the local health, which is, of course, the counties are the touch point for that. So that's why I was asking, because I'm thinking of, are there things that at the county level that could or maybe are being done around lung cancer screening, equitability, thoroughness, et cetera?
That's a really great question. So We're still very much in the discovery stage. So we had a great meeting last week with some of our DHS leadership. And I think just as was suggested earlier, we have a very different population and a very different system at UC, and we acknowledge that. And we've tried to come in with a great bit of humility and saying, help us figure out the words to say, the language to speak, the issues that are most important so that we can fit what we see as a really important resource for patients into the greater agenda. And it's going to take a lot more meetings to figure out how to do that. But one thing that really rang true for me and really stood out for me is the issue of equity, which you mentioned. So, looking across the country, what are other FQHCs, what are our other large safety net institutions able to do with the resources that they have? County now has a way to order a low-dose CT, but there's not yet a structured, centralized lung screening program to say, contact patients when they're due for their annual screen, right? Or to, in a very specific way, navigate them to a bronchoscopist or a pulmonologist based on the results. So, my natural inclination coming from UC was thinking, okay, I have to make a business case for why this is a good idea. And county has a very different way, a very different structure, very different motivation. So we're listening, we're learning, and we're trying to adapt to that environment and figure out how to work with DHS partners. So not just coming in and saying, we're going to prescribe this to you, or we're going to make these recommendations, but how can we feed off of each other to get the best impact? So we'll have to report back to you.
Well, thank you. No, I really appreciate that. You say, though, just to clarify, you're working with Department of Healthcare Services in terms of, you say DHS, and rather than CDPH? And if so, who is the person at DHCS who you've been working with, or maybe a group?
Yeah, so we started out with radiological services, because this is a radiology exam. So speaking to some of the county radiologists and their leaders in the radiology services, but I know Dr. Cummings has had even deeper dives at higher levels than I have, and I'll let her weigh in.
Yeah, and just, as a little bit of the history here, these conversations started with Hal Yee, who has since retired, and Nina Park has taken over for her. But, we are working with radiology and sort of primary care and pulmonology champions at this point, and trying to see what we can figure out. And again, I think another big, distinction we need to make in this system is that there's, sort of a set number of impaneled patients, but there are far more that are going to come through the emergency room for their very first care that could be eligible for screening moving forward. And so how do we kind of address these two different types of populations that we see within the system, and kind of coming up with comprehensive support for sort of the whole continuum that you're going to see there. And again, the FQHCs, I think are worried about downstream care, and rightfully so. And again, that's going to continue to be a big focus for us.
Thank you. Thanks very much. Really appreciate it.
Thank you. And I think I saw Lucy's hand. Go ahead, Lucy.
Oh, I was just going to make a quick comment about what Dr. Nodoran brought up, which had to do with the FQHCs. I think previously working in one, something that comes to mind has been not having a low-dose CT scan like in the facility. So I think, there's resources where we are able to see how far the low-dose CT scanners are from the FQHC. So I think that is a good starting point for us to kind of think about when collaborating with them. So yeah, that was just like a thought that came to mind. And that was it. Thank you.
No, that's a wonderful thought. And I would say, I certainly one that we're interested in, and because there are lots of different types of imaging centers in Los Angeles County and of course throughout California. And then there are some that do sort of work with the Medi-Cal reimbursement rates and sort of where are these located, what's the access. There are certain areas that are very resource poor in Los Angeles County and multiple places of California. And so if we identify those, is there a distinct strategy that will emerge that will help us capture that? And again, mobile CT screening has been kind of a big topic as of late, so can we, use these in meaningful ways to address those needs? We're very excited in this space.
And then we have a question from Raquel. Raquel, do you want to go off mute?
Yes. Hello. Thank you so much. I appreciate you guys so much. But the question I had was on ucscreenca.org. I'm just wondering if you have an update on how the navigation component is working, just, navigating people that might be eligible to the appropriate next steps to confirm that, and then to the screening facilities.
Yes, no, that's a great question. And there are different prongs that go along with this. I will say to date that UC Screen has mostly been advertised internally to already pre-existing UCLA patients. So the vast majority of people asking for navigation have been, either a UCLA patient or in the area. And so that's one component of it, but we're certainly getting referrals from different places in California. We had one that came up from Santa Cruz. And so, in that situation, we're leveraging our network of people we know in that area to do a warm handoff. And then, of course, the power of the platform is the ability to check back in over time with text messages or automated emails, just to make sure that the sort of, loop was closed, that the person did get the screen, that they have their information about when their next scan is going to be scheduled, and that they have the ability to get alerted when when they need another scan, in that 6 month to year time frame. So there are, sort of multiple components here. The new iteration of UC Screen that's going to not be specific to the UCs and is going to be more broad, is going to have a new navigation component to check to see if a patient is already established with one of the main medical organizations in our area. And it's going to be sort of a geographically sort of set thing. And so that's going to help us, use our partnerships with these other groups that we've been working with, because the idea is that we don't want to steal patients. We just want to improve pathways to access. And so the more that we can get people, the care that they're used to and comfortable with, that's what we want to do. And that's the whole point of the coalition and doing these local regional partnerships, so we can start to share how best to do that. It's a great question.
Thank you, Raquel. Thank you, Dr. Cummings. Do we have any other comments or questions? Very great question and answer. Thank you again. I guess hearing none.
I had one more comment, sorry. I just thought it was really interesting that when Dr. Prosper, you were showing where patients or potential patients are stopping in the survey is like exactly when I think about primary care providers, when they like the barrier, it's like the same, right? Like it's calculating PAC years. So I'm really excited to hear how we're rephrasing these questions, and maybe even testing that out with some PCPs to see if it could work as well. But that was it. It was just a quick comment.
Thank you, Lucy.
Yeah. Glad that resonated.
Right. All right. Thank you once again, Dr. Prosper and Dr. Cummings, for gracing us with your expertise and time with our Cancer Center partners today. So we will share your contact information if it's okay, and then the available slide deck after you. And then the recording, if you're not okay sharing the recording, we'll edit the portion where we would omit that presentation. And then I guess I'd like to pass it on to our program director, Shante. She have a few items to share. Or do we have time, Shante? If not, we're
at time. So we have another convening in October that we can talk about these items. And we may even send something via email before then. But yeah, we're very grateful for everyone's participation, and especially for Drs. Cummings and Prosper joining us today. Thank you.
Thank you so much. All right, everyone. We'll see you in October. And if you have a chance, please complete the short evaluation survey. Thanks for staying in.